Good afternoon, everyone. Thank you for joining us today. This webinar is supported by Satellite Healthcare, and we thank them for their support. My name is Melanie Paris, and I'm the Senior Director of Health Initiatives and Education here at the American Kidney Fund. Before I turn the presentation over to today's speaker, I'd like to direct your attention to the control panel you see on your screens. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the section of your control panel titled Questions. We'll see your questions and we'll do our best to answer them, either by replying to you in the questions box or out loud during the last several minutes of the presentation. This webinar is being recorded and will be made available for viewing on our website, kidneyfund.org/webinars, within the next 1 to 2 weeks. For those of you in attendance who are health professionals, we're glad that you've joined us today and hope you'll recommend this webinar to the patients you work with. However, as a friendly reminder, this webinar is not accredited for continuing education credits. If you believe that your accrediting body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidneyfund.org. Without further ado, allow me to introduce today's speaker, Dr. Randy Chen. Dr. Randy Chen has been a practicing nephrology in private practice for 12 years in San Mateo County. He sees over 350 dialysis patients along with his partners and has just as many patients with CKD that he also regularly sees. He has a special interest in slowing the progression of chronic kidney disease and improving the quality of lives in patients with kidney disease. Besides treating, he's an expert in high blood pressure management, electrolyte, and acid-base disorders. Dr. Chen has won 3 consecutive awards as a medical director for his dialysis unit for outstanding patient care and leadership for Satellite Healthcare. No other director has received 2 awards the same year or 3 consecutive awards during their tenure. He tries to use education and self-care to aid patients in the self-management of their medical problems. Thank you, Dr. Chen, for joining us.
Thank you very much. Good afternoon, everybody. Thank you for the introduction. I hope this talk generates some interest in speaking with your physicians more about chronic kidney disease and also the awareness of how to manage it if you have chronic kidney disease. So I'll briefly go over some basic stuff before we get into the actual questions that a lot of you have, which I hopefully will address during this talk. So if you are not aware of what the kidneys do, they filter out blood. So as you can see here in the diagram, there are some things called nephrons. So basically all blood gets filtered and the blood does not get filtered out. It's too big to get filtered. It's kind of like a spaghetti strainer. You don't have meatballs, falling through your strainer if you strain the water out. So only the water, electrolytes, and waste products go, and they eventually much of it gets reabsorbed. But that which is not reabsorbed is turned into urine or processed into urine. So besides cleaning your blood, the kidneys also help with making blood. So there's a hormone released from the kidneys that helps you to produce blood so that you don't get anemic. And also because the kidneys are helping to regulate water and sodium and everything, they can affect your blood pressure. Particularly there's some hormones that could get affected and released through the kidneys. And also bone and mineral balance as well. So they do a lot of things, a lot more than just cleaning, but that's their primary function. Next slide, please. So what is chronic kidney disease? Well, chronic kidney disease just basically means that your kidneys are not functioning to their full capacity. And we measure blood tests. You may have heard of creatinine or glomerular filtration rate. These 2 terms might be used by your physicians, or you may know of them, and they are really what kind of tells your doctors how well your kidneys are filtering, okay? So if you have a persistently higher creatinine than you might be expected to have in a person of your age, that means your kidneys aren't really cleaning the blood at their 100% capacity. Now that doesn't mean you're getting poisoned or anything. That just means that you're filtering process is not completely normal because some of your kidney cells are damaged, okay? Now, the GFR is basically to simplify it, I tell people it's like a percentage of kidney function. So when you're born, you have like over 100%. Well, let's say you have 100%, but as you age, you gradually lose some of your kidney function. And, you know, if you drop to like a GFR of 30, that means your kidney function, both of them are functioning in terms of filtering at about 30%, okay? So there are 5 stages, and we'll get into that. Most people that I see are in stage 3, and oftentimes they don't progress if we treat them medically and people take care of their health better, okay? And when the kidneys can't filter out waste products, in the late stages of chronic kidney disease, you can have worsening health problems. You can get anemia. You can get other issues like edema or swelling because of inability of the kidneys to get rid of salt and water, etc. Okay, next slide, please. So there are 5 stages of chronic kidney disease. This chart is just basically to tell you a couple things, and I'll point out the major things. If you have severe kidney disease, it's mostly when your glomerular filtration rate is below 30. So see these, if you see the red table marks there, that means you're at higher risk for worsening kidney function and perhaps even risk for needing dialysis. That, along with high levels of protein in your urine, both of those things are very significant, and that's when your physicians start to get more concerned, is if you start to have lower GFR and high protein in your urine. Those aren't the only things, but they are very, very significant markers of poor outcomes in terms of your renal function. Next slide, please. So in terms of in the US, based on this surveillance system, 14.8% of people in the US have chronic kidney disease, and that's based on population data. 30 million people have chronic kidney disease in the US, and 500,000 people are on dialysis. So, you know, 30 million people have chronic kidney disease, but only 500,000 have dialysis. It's not a huge portion, but obviously it's a very big problem. And if you're at risk because you have progressive chronic kidney disease, we obviously want to keep you off dialysis and slow the progression of chronic kidney disease, because many, many people have chronic kidney disease. Next slide, please. So what causes chronic kidney disease? Well, any process that can lead to damage to kidneys or scarring. You know, if you get a heart attack, your heart gets damaged. If you have cirrhosis, your liver gets damaged. So things that can damage your kidney and cause those cells to get injured and not be able to recover or scarred up will lead to chronic kidney disease. And as you lose more and more cells or nephrons that I showed you that picture of in your kidneys, you can develop chronic kidney disease. So the major problems that cause chronic kidney disease in our population are diabetes and high blood pressure. So diabetes is the #1 cause of chronic kidney disease in the world. If you have diabetes, there's a high chance that you might develop chronic kidney disease at some point in your life. And in our population, there are about 1 in 2 people with diabetes or pre-diabetes, and they might develop chronic kidney disease, okay? High blood pressure also, particularly if you're not controlled, can lead to damage of the small arteries. The arteries that filter your blood, those can be damaged, and the arteries that bring blood to your kidneys, the very, very small ones, are really the ones that get damaged when you have high blood pressure. Some other medications that I advise my patients to avoid if they have kidney disease are ibuprofen or non-steroidal anti-inflammatories. These are available over the counter. You know, you can buy them anywhere, but they can be very dangerous in patients who have chronic kidney disease or are prone to them. So I caution you to check with your doctor if you have chronic kidney disease, and in general, I ask that people avoid these classes of medications, okay? There are other specific diseases that can cause damage and inflammation directly to kidneys, such as lupus and other things. And if you have these conditions, most of the time your physician can figure out if it's causing any damage to your kidneys. And if you need, you can be referred to a nephrologist for help in management. Next slide, please. So how will you know if you have chronic kidney disease? Well, there's not a lot of symptoms. People go, well, I don't feel anything. How do you know I have kidney disease? Well, you won't feel anything, just like you don't feel high blood pressure sometimes, even if it's moderately elevated. And a lot of people, even if they have it and have had it for a long time, don't even know. There's studies that show this. And it's not that your physician's trying to hide anything from you, but there are a lot of medical problems you might have, and perhaps your chronic kidney disease has been very stable or very mild. So there's no reason to get alarmed about it. But the blood test and your urine test, as we talked about, your GFR, which is calculated from your blood, creatinine, and your urine test, which might indicate damage or inflammation to your kidneys, can reveal chronic kidney disease. And the creatinine is used to estimate your glomerular filtration rate. And CKD is often related to diabetes and hypertension. So if you've had complications from these already, it is very likely that you have chronic kidney disease, even without symptoms, and even if your blood tests appear somewhat normal. Next slide, please. Should you be worried about it? I think in general, most people remain fairly stable, but there are signs that and symptoms that do worry me. So if your GFR, I often will put a graph and show my patients about their GFR and say, listen, here, back 5 years ago, your GFR is 60. Now it's now 5 years later, it's 30. You've lost, you went from 60% function to 30% function in 5 years. That's not a great sign. So we need to do something to slow that if possible. And so if your creatinine starts to or continues to go up and your GFR continues to go down, obviously that's not a good sign and you should probably be more concerned. If your diabetes, high blood pressure, and other medical problems are not in control, often that's a poor predictor of worsening kidney function. And if the protein is high in the urine, so I check that quite often. Sometimes your primary care doctor may check that periodically, but I check it very often because I like to see the pattern to see if it's stable, worsening, or in fact maybe improving with some of the medications that we use that I'll talk about. So if your kidney function seems to be getting worse, your primary care physician may often say, yeah, it's a little of concern. I need you to see a nephrologist or kidney doctor and may refer you to see someone like me. Next slide, please. How fast does it progress? Well, there's not a great answer for that, but oftentimes it correlates with how well your diabetes and high blood pressure are controlled if you have those, or how controlled your other medical conditions are. But it also depends how bad off you are in terms of your stages. Like if you're at stage 4, it tends to progress more quickly than in stage 2 or stage 1. And also if you have diabetes, it progresses more quickly, and if that's the cause, if it's diabetes, than if you had something like hypertension as the major cause. So getting blood tests and doing them, more often than perhaps once a year to see the trend is probably advisable in patients who have particular stage 3 or later chronic kidney disease. So the poor control of your health issues, the more likely it might progress. But however, if people want a hard number, which oftentimes they do when they see me, if they're at stage 4, I'll often tell them they're going to lose 1% kidney function per month if they have diabetic nephropathy. So like, let's say you're at a GFR of 20, in 10 months you'll be at 10, and you might need dialysis at that point if you have pretty severe diabetic nephropathy, okay? So what I tell patients is like the GFR is the rate at which the train is, if you're the speed at which the train is, the rate at which the train is going towards the cliff, or how far you are from the cliff, let's put it that way. How far you are from the cliff, and the protein kind of gives you how fast the train is going. So I didn't say that very well, but basically the train, if you're closer to the edge, that means your GFR is lower, but if there's a lot of protein, that means it's going to go pretty fast. Okay, next slide, please. Can you reverse chronic kidney disease? Well, injury to the kidneys, where you get scarred up kidneys because of damage from diabetes and high blood pressure, is not often reversible. Once those cells are scarred up, you can't grow them back. It's just like if you have a major heart attack, you don't grow heart tissue back. It's gone. There are conditions in which you can recover some kidney injury or recover from some kidney injury, but if you have progressive chronic kidney disease, most of the time that's permanent. And the example I give is like, you know, if you lose a finger, you can't grow that back because that tissue is gone. However, you can slow and prevent further injury to your kidneys or even stop progression of chronic kidney disease. So I don't want to tell people that, yeah, there's no hope that you can't slow this or just stay very stable for many years. Next section, please, or next slide. So I had a dietitian help me with this because I get many questions about diet. Almost every visit I get about diet. Now, you may notice that your physician is not a dietitian and expert in dietary issues and may go, well, you know, I don't know, or, you know, kind of give you some general recommendations. And, you know, in fact, there is a lot of education that needs to be done, but oftentimes we don't have the time and resources to do that. And there are not a lot of renal dietitians out there. So unfortunately, that education portion is missing in a lot of care, but I think most of the time it's pretty common sense, okay? So, and you'll see in these next slides, most of the dietary recommendations are just pretty much common sense or general, okay? But my renal dietitian, Lauren Levy, asked me to tell you to these major points, and I'll comment on some of these. And I also put in my own input. Of course, you want to limit sodium or salt, okay? Don't add extra salt. Try to buy things that are less salty, and try to avoid processed packaged foods because those are tons of salt and additives in those things, and oftentimes are very unhealthy for you, okay? Limit protein if advised by your physician, but that's not just a blanket statement, and we'll go into that a little bit. Protect your heart. Eat heart healthy, meaning don't eat packaged processed food. Try to stick with natural whole foods. That doesn't mean you have to avoid anything with fat in it. In fact, you may know that there is a change in philosophy about fat and eggs and whether you should eat those things. And that's actually becoming more scientifically proven that they're not as harmful as once thought. And maintain your blood sugar in a good range if you have diabetes or are prone to diabetes or have prediabetes. Dietary management is not only important to help kidneys, but in other general medical problems too, such as diabetes and heart disease. Okay, very important. Next slide, please. So, you know, the FDA has made it a law that all packaged foods and most foods need to have these labels with nutrition values on them. They're very easy to see, and they tell you how much sodium, how many carbohydrates, how much protein is in foods. So pay attention to these things. Now, there are a lot of applications out there. Everyone has a smartphone, you know, iPhone or, you know, Android phone that have these applications that you just plug in, like, oh, I ate a cup of broccoli, and they'll tell you how many calories, how much sodium these things have them. The libraries are very comprehensive, and I use these myself to see how many calories I'm eating and if I'm watching my sodium. And this will help you stick to your goals and we'll go to some of these goals in the next slides. Next slide, please. Reduce your sodium intake. So, you know, most fresh foods don't have a lot of sodium in them. It's what manufacturers do when they process your food to make it taste better. So packaged foods often have added salt for taste, and because no one wants to not sell their product, and salt makes things taste better. Eat less than 2,300 milligrams of sodium per day, or 2.3 grams. Okay, and it's very easy to calculate that if you watch nutritional labels or have these food diaries, food libraries, such as I'll just say MyFitnessPal is the one I use. Do not add too much salt to foods. Most foods have natural flavor, and why hide it with salt? Although you can enhance it, like with products that you may have heard of, such as Mrs. Dash and other things, without, you know, particularly try to avoid MSG, but, you know, natural flavorings, okay? Read the food labels. A meal that has more than 20% of daily value in sodium is high. So 400 milligrams, I'd say. A snack that has more than 5% of daily value is high in sodium. So just stick to the lower sodium products and stay under 2,300 milligrams daily total of sodium. And limit canned foods. Canned foods always have salt. Even the canned vegetables have more salt than they should. And if they do have, like if you eat like canned corn and things like that, rinse it off if you can, or buy the no added salt corn. Next slide, please. Reduce your protein intake. Now, this is not a blanket statement, but if you have stage 4 chronic kidney disease and you're and the doctor feels you may be at risk for progression because you have high protein levels in your urine, you're showing progression, you're supposed to eat less than 0.8 grams per kilogram of protein a day. Now, most of us aren't math wizards and don't want to do the math, so I say about 60 grams, and because that's about based on a 70 kilogram person, and that's going to be about the half a pound total. So 3 decks of cards total. So if you eat a deck of cards size, like let's say a piece of fish, a regular piece of fish, not a giant fish, like not a whole side of salmon, that's about the right portion size. And you can eat 3 of those a day. Okay, 3 decks of cards. And about 7 grams equals 1 ounce, so about 8 ounces. So but basically I think the 3 deck of card things, maybe the size of a fist, but everyone's fist is different size. There's a lot of what's it called, estimated sizes of how much you can eat, but 60 grams is about it. So but eat mostly vegetables, and then you need some protein, but stick with the plants and vegetables as your main food source, particularly if they're not starchy vegetables and they're healthy vegetables and whole and not packaged, okay? Good sources of protein include eggs, okay? Don't worry about the cholesterol and fat in eggs. That's usually pretty healthy kind of stuff. Chicken, fish, beans, and nuts. Next slide, please. Cut back on unhealthy fats. Okay, fats are not your enemy, but bad fats are the trans fats, and they definitely are associated with heart disease. Saturated fats are not the best. They can, but unsaturated fats are actually good for you, okay? Fish like salmon, sardines, eggs, nuts, these kind of, and olives, olive oil, avocados, coconut oil, they all have actually unsaturated fats, which are not unhealthy, okay? It's the saturated and trans fats that are not quite healthy. But even if you do eat fatty meals, it doesn't guarantee that you're going to get heart disease, okay? And we're showing that. But you should stick to leaner cuts of meat if possible. I wouldn't go out and eat, really fatty steaks every day, of course. You can have these things, but in limitation, okay? So stick with leaner cuts if possible. Cook meats using olive oil or olive spray or baking, sauteing, anything that's going to limit added fat and added saturated fat. Don't use, the vegetable oils and things like that. They have trans fat in them. And most meats, you can use one of the Teflon coated pans, and then use a very light amount of oil or cooking spray to use those, okay? But olive oil and nuts, you can eat a little bit more of those, particularly if you're trying to cut down on your carbohydrate intake. Next slide, please. This is very key. Now science is showing that we're not supposed to eat 7 portions of grains and cereal and pastas and things every day. In fact, we're getting away from some of that. The nutritional recommendations are changing from about 20 years ago when we looked at that food pyramid. So you want to manage your blood sugars and use medicines if necessary, but I'm a big proponent of diet and doing some extra activity to lower your sugars. I don't think throwing a medication to anyone who has diabetes or prediabetes is the answer. If we limited our processed carbohydrates, which the desserts, candies, sweetened vegetables, anything that makes you crave sweetened things as well, is very important too. So try to avoid anything with added sweeteners, particularly high fructose corn syrup. Eat meals consistently. Don't, eat a whole bunch at one time. Try to, but, then again, don't eat 7 meals per day. There's a little bit of a controversy about that, and this talk doesn't allow me to comment on that, but I'm actually more of a proponent of, not eating several snacks a day, which was previously, recommended. But I think, watching your portions, don't overdo it, I mean, caloric intake with a lot of carbohydrates obviously has contributed to obesity, diabetes. And the reason why I'm talking about carbohydrates is because diabetes is the #1 cause of chronic kidney disease. And if you're eating a lot of carbohydrates and processed sugars or refined carbohydrates, such as high fructose corn syrups, you're going to be at higher risk of diabetes. Okay, next slide. So people look on the online and say, oh, it says I can't eat potassium or phosphorus. However, that's rarely the case. That's only if you have advanced chronic kidney disease. So my caveat to this is don't always believe what you read on the internet. Okay, don't Google and say, oh my goodness, I've been eating bananas. I can't eat bananas anymore. That's not most of the times that's not the case. And people tell me, well, I've been limiting my bananas and beans and and I said, well, why? You have stage 3 chronic kidney disease and your potassium's fine. However, if there are reasons to do that, you will be advised by your physician and they'll look at your potassium and phosphorus on your laboratories many times. Okay. Phosphorus containing foods, if you have advanced chronic kidney disease, such as nuts, dairy, those might be needed to be limited, but don't do it unless you're told that you need to do that. And at times potassium foods. The problem is that sometimes you're on medications which can make your potassium go up. And I'll talk about those later. They're very important medications, but oftentimes they disrupt your potassium regulations because they make the kidneys less able to get rid of potassium. And so a physician might tell you to limit your potassium intake by cutting out bananas, prunes, orange juice, melons, high potassium containing foods, okay? Next slide, please. All right, so shifting gears to medical management. Now, this is what I referred to in the last slide. Renin-angiotensin-aldosterone system inhibitors will block harmful hormones that may worsen kidney injury and damage over time, okay? Now, that's scientific mumbo jumbo, but the bottom line is there are medications called ACE inhibitors or angiotensin receptor blockers that are very, very useful in patients with chronic kidney disease. Nearly all my patients with chronic kidney disease are on these medications unless they have a problem with potassium or worsening kidney function. You may read on the internet or be told, oh no, these medications can worsen your kidney function, but that is not true in most of the cases. However, there are times when we have to stop these medications because of the side effects of high potassium and worsening kidney function. But what these medications do is actually lower blood pressure inside the kidneys. Now, if diabetes damage and high blood pressure damage to the kidneys is mostly mediated by high blood pressure within the kidneys, along with high sugars, then it makes sense that we want a medication directly targeting high blood pressure inside the kidneys. Now, it's very interesting, but it's probably a little too complicated right now to go into. But let's just say that these medications decrease the blood pressure inside your kidneys by decreasing the blood flow going into your small blood vessels that filter blood, okay? And also lowering your blood pressure with other medications is going to help protect your kidneys as well. But our mainstay of treatment is these RAS inhibitors, okay? ACE inhibitors or ARBs. Those are the things you may have heard of. Next slide, please. Goal blood pressure now, there's been some fluctuations. Used to be if you're older, it was 140/90. And now we're seeing 130/80 is a better target for most individuals because it also lowers your chance of getting cardiovascular disease, which is actually one of the biggest causes of death in patients with chronic kidney disease. It's not kidney disease itself, it's actually heart attacks and strokes, okay? Most patients should be on a RAS inhibitor that I mentioned, an ARB or an angiotensin receptor, or ACE inhibitor. And sometimes diuretics are used. And now you may say, oh, well, I heard diuretics are going to harm my kidneys. No, they do not usually cause permanent injury unless you use them and you're always dehydrated and you start getting problems with really low blood pressure because of them. But oftentimes they're very necessary because you might get edema, which is a scientific term, or swelling. And it's because the kidneys can't get rid of sodium and water, which, as we spoke about, is one of their main responsibilities, as well as they should, because they don't function as well, okay? So sometimes you will be on a water pill or prescribed a water pill, and your physician can make that decision. Okay, many patients with chronic kidney disease need more than one blood pressure medicine to get to goal. So sometimes you'll say, well, I keep adding medicines and I'm already on a blood pressure medicine. Well, in fact, you're not at goal, and that's why you have to attack getting that blood pressure down by different meds that work very differently from one another. And sometimes when they work together, they actually do a better job than if you're only on one medication in general. Next slide, please. Diabetes and glucose control, obviously very important. As I said, diabetes presents the greatest risk of progressive chronic kidney disease if it is not controlled, and it is crucial that you control your sugars and get them to goal, okay? Speak to your doctor about what the goals are. I'm not getting into that because it's very complicated, but we look at the hemoglobin A1C, and we look at how well you're doing with your diet, if we need to add medications, particularly that can help tighten your sugar control, but also don't make you gain weight and have problems down the line. Insulin is the last resort, I believe, and I'm not a big fan because once you're on insulin, it becomes really, really difficult to control your weight. And, you know, it's just very difficult for many people to give insulin to themselves. So hopefully we can intervene before your diabetes gets to the point before you need insulin. Okay. Next slide, please. Lower your risk of heart disease. As I said, heart disease is the number one, and stroke is the number one killer of patients with chronic kidney disease. So, you know, one influences the other. If you have CKD, you're at higher risk of coronary disease. If you have coronary disease, you're high, you know, cardiovascular disease, you're at higher risk for CKD. So, the most major risk factors for heart disease are the same as in chronic kidney disease. So, diabetes, high blood pressure, smoking, obesity, hypercholesterol, all these things are cardiovascular risk factors and can lead to higher risk of chronic kidney disease. Also, physical activity can increase your cardiovascular health, and it's always good because you know, you want to keep your circulation healthy. Okay, next slide, please. Okay, potentially harmful medicines. People say, well, is there something I should definitely avoid so that my kidneys don't get injured? Be careful with using over-the-counter medications and also these herbal things. You don't know what's in these things. They're not regulated by the FDA. People say, well, I get all these aches and pains, you know, doc, well, you know, so I take some Motrin, you know, they don't even mention it until I ask them specifically. Yeah, I take naproxen, I take Tylenol, I take Advil PM because it helps me sleep. And I say, wow, stop that because that's gonna really increase your risk of damaging your kidneys. So if you have chronic kidney disease, I generally say avoid these things, okay? Because I've seen people who've taken too much and end up on dialysis because of it. Watch your dietary supplements. I know there's a lot of herbal things out there that are being pushed, turmeric, green tea extract, you know, all these things. But, you know, bring the bottle in if you have a question and say, hey doc, is this safe? You know, don't just say, I take something, but I don't even know what it is, and is it safe? Because your doctor's not going to be able to tell you. But remember, these things, they say they have things in them, but there's no one monitoring if they're being true about what's actually in these things. Okay, so be careful. Proton pump inhibitors, everyone is on these things because everyone has acid reflux, right? But just be careful with these medications. Sometimes people get put on them because they have like a bout of reflux and then they never come off them. So there are a lot of people who need it because after they stop them, they get really, really bad reflux. And sometimes this really bad heartburn and acid production can lead to increased cancer risk in your esophagus. So obviously we don't want that. But sometimes people are on these things and never stop it. And they said, well, I just started it and no one ever told me to stop it. So sometimes I'll say, do you really need this? Do you want to try getting off of it? Is your heartburn okay? Are you avoiding the things that are causing heartburn? Like, did you stop coffee and mints and gums and things like that? And that can, like, you know, that can cause your reflux, and I'll try to get people off these. Anyway, these have gotten a lot of press. You may have seen on late night TV or whatever, you know, legal ads about, you know, omeprazole, etc. But talk to your doctor about these kind of meds, okay? And always talk to your physician about the medications you're on and disclose what herbal medications you may be taking or over the counter. Next slide, please. Some medications might need to be adjusted, so make sure you tell doctors what doses you're on. Just don't say, well, I'm on, you know, metoprolol or I'm on this antibiotic and don't have the dose. We need to sometimes adjust the amount or the dosage of the medications because the kidneys can't clear that medication as well. Sometimes medications need to be avoided completely because they can cause life-threatening problems. Metformin is a very popular medicine, but if you're like stage 4 chronic kidney disease and you're taking metformin, and perhaps maybe you said, well, I like that medicine and I had some lying around, I start taking metformin again. Don't do that kind of stuff because metformin can be deadly. And I've seen several cases, and it's almost, if people get toxicity from it because they have very bad kidney disease and they take it, the mortality or the chance that you'll die from it is nearly 100%. Now, that's a very rare complication, but if you get it, it's nearly almost fatal. So please tell your doctors if you take, you know, like, don't take medications unless you're prescribed them, and also make sure you have the right dosages. And antibiotics, as I said, make sure you have the dosage correctly. I often get calls from doctors just to check to make sure if that medication dosage is appropriate or not. And there are many resources that doctors can look at where we can see if we need to make dose adjustments to medications. Okay, next slide, please. So water and water pills, I talked about that. People go, do I need to drink a lot of water to flush my kidneys? Not necessarily. In particular, people have congestive heart failure, they get swelling, they are often on water diuretics for purpose. So I say, yeah, you can drink when you're thirsty, but don't try to drink more because that's why you're on furosemide or Lasix, okay? That's because you don't get rid of water. So why would I want you to have more water if we're trying to get water off your body? Okay, because not only do they these medicines block sodium retention, but they also block water. Okay, well, water diuretics such as furosemide, bumetanide, furosemide, all these water diuretics, hydrochlorothiazide, chlorthalidone, will they cause permanent damage to my kidneys? No, not unless you get really, really dehydrated and you're in that state for a long time, usually because your blood pressure drops and then your kidneys start to struggle because the blood pressure is low, not because the medicine itself is causing direct harm. And often water diuretics are necessary if you have congested heart failure or you're prone to retain water and salt. And also they help to control blood pressure often, because if you get water and salt off your body, there will be a chance that your blood pressure will come under control. You need to work closely with your physicians in order to maintain correct salt and water balance if you have chronic kidney disease and if you have a problem with this, and your doctor will know. Okay, next slide, please. Problems that can be caused by chronic kidney disease, well, there's a whole slew of them. High blood pressure, electrolyte and acid-base disorders, fluid and sodium retention, anemia, bone disease, and at the very, very late stages, uremia. At this point, you're going to need someone may need dialysis, and that's how feeling poorly, having no appetite, and confusion. But that's when your GFR is below 10. So those are very, very late stages. But the other things, if you have more advanced chronic kidney disease, a nephrologist will be paying attention to these issues. Okay, next slide, please. So stage 5 chronic kidney disease, or the stage at which you need some therapy to replace your failed kidneys, are dialysis and transplantation. Okay, how do you know when it's time for dialysis and transplantation? Well, then you should be seeing a nephrologist if you're at stage 5 chronic kidney disease, or stage 4 probably, unless it's been very, very stable. And we look, as a nephrologist, I look at many different lab tests, symptoms, and work with you to say, well, you're feeling poorly. It's an indication that these toxins are building up in your body. You're having trouble with too much fluid and we're not able to get it off with water pills, and the medicines aren't working anymore. So it's probably time to consider dialysis. Transplantation is also an option even before dialysis. It's called preemptive transplant, and when your GFR drops below 20, your nephrologist may refer you for transplantation. Now, because of the waiting time for transplantation, if you're waiting for a deceased donor transplantation, that means getting an organ from someone who has passed away. That can be quite long, on the matter of 5 to 7 years at times. But if you have a living donor, that's the best choice. And if your GFR is below 20 and you're at risk for progressive chronic kidney disease, you might be actually referred for evaluation for transplantation even before dialysis. A nephrologist will make that decision and talk to you about what dialysis means, what options I have, and what transplantation is, and what I would need to expect. Okay, next slide, please. What if a loved one has CKD? A lot of you are on this webinar or listening to this webinar because you want to know, well, my husband has CKD and I want to understand and I want to prevent him from having worsening chronic kidney disease, okay? And I think the most important thing is to understand that CKD in itself often is a result of other medical problems like high blood pressure and diabetes, okay? So you have to really understand that the nephrologist, your other doctors are trying to control your other medical problems, okay? You need to live a healthy lifestyle and you yourself actually should live a healthy lifestyle so that your partner or loved one will follow your example and try to also lead a healthy lifestyle. There's nothing worse than, you know, getting to retirement and then your health is so poor that you can't enjoy yourself because your health issues are so poor, are so prominent. So I would encourage following medical recommendations if they sound reasonable to you. I mean, we're not always right as doctors, but we try to base our treatment on science. You know, some of you go, well, I don't want to be on this medicine because I don't want more medicines, you know, and I'm going to try to improve my general health. And I think most physicians should support you, but when it's time to go on a medication, I think oftentimes there's a good reason for it. Go with your loved ones to their appointments. Be involved. Learn about chronic kidney disease so that you can support them. If you're not at the appointment, you'll never know because you know how it is. You go, well, what did the doctor say? Well, you know, they'll say, oh, he said something about, you know, my blood pressure and, you know, gave me medicine. But if you're there and you can understand the reason why the physician is doing what they're doing and ask them, you know, educational questions and educate yourself, I think that's going to really help to support someone with chronic kidney disease, in particular patients who are faced with dialysis or on dialysis. And give your emotional support. Don't try to criticize and say, well, if you'd taken better care of yourself, you wouldn't be in this position. Yeah, that's true for anything. But, you know, if they're facing dialysis, the last thing a loved one wants to hear is that, you know, it's all your fault. And, you know, I think we really need to support our patients because it's really life-changing if you have to go on dialysis, and that's why I try my best to keep people off dialysis. Okay, next slide, please. Living with chronic kidney disease. Listen, it can be slowed, it can be treated, it often can't become reversed, but it can be slowed in its tracks. But most of my patients have CKD3, and I see them on a very, you know, periodic basis, and they're very stable because their blood pressure is good, their diabetes controlled, they're not taking medications they're not supposed to, yet they're taking the medications they are, but they've improved their overall health style and they're happy. And that's what we want to see, is that despite having a chronic condition, that people are living happy, healthy lives. And there's always hope for patients with CKD. If you have chronic kidney disease, don't fear the worst. Don't, imagine the worst. Even if you need dialysis, there's always hope that, we can get a transplant. You can live on dialysis if you're, quite elderly with many medical problems, and dialysis is your only option. There's always hope that your life can improve. Next slide, please. Okay, so I left, we will have some questions and answers, and our moderators will be taking any questions you have that may have arisen at this point.
All right. Well, thank you, Dr. Chen, for leading us in such an interesting webinar. At this time, I'll go ahead and ask you some questions that we've received over the course of the webinar. So, one question, at what point do medicines like ibuprofen and aspirin damage the kidneys? Do they have to be taken in large quantities for the damage to occur?
Very good question. Sometimes it's, we call it idiosyncratic, which means that just a few doses can cause the problem. But most of the time, I see it in patients who take it quite often, like on a daily basis or several times a week. So most of the times, it's in patients who take, 400 to 600 milligrams once or twice a day, nearly every day, for their various pains. Now, obviously, there are conditions like when you're younger, athletes take this by the handful to decrease inflammation. Sometimes you have arthritis that's inflammatory. But I'll often say, listen, is there an alternative if you need to be on this medication long term and in moderate doses, moderate to high doses? So I tell my patients with advanced CKD, don't even take it at all, don't even risk it, because we can't reverse that damage if it's done. But oftentimes I'll see most of the damage and injury occurring in patients with moderate to high doses on a daily or frequent basis.
Okay, thank you. Another question. I've seen lots of herbs and herbal teas claiming to cleanse organs such as the kidneys. Are these legitimate? Are there any recommended herbal remedies or natural treatments for kidney health?
Yes, good question. I'm not, I believe I'm trained in medicine, so I believe in scientific data, empiric evidence that's proven through rigorous scientific process, okay? So in Nerd Talk, that's basically, if it's not shown through, research to provide benefit, like through, when the medications that come out through the pharmaceutical companies are tested, they go through rigorous testing, okay? And that's why we know they work. Yet sometimes, a few years later, I'll see this medicine that was saying, you got to take this medicine, and then it's withdrawn from the market. So I'm not saying it's perfect, but these herbal medications are not regulated by the Food and Drug Administration, so you never know what they are. So I advise caution. Yet, I'm not against trying some teas, green teas, some natural remedies, turmeric, these kind of things for general health purposes. But there's nothing out there that I believe has been proven to slow kidney damage or improve kidney health. That's an herbal remedy at this point. And that's also because they have not undergone large trials. Okay, but I would talk to your doctor about any herbal medications you take or want to take. But I think most of the time, there's something called snake oil that will, and that's an old term, but it's that thing like, this will cure all your ails, it'll cure your liver, and they've been around for like, centuries. So I would avoid the snake oil, and in our current age, I think those are these herbal cure-all remedies that they're claiming help kidneys, okay?
Okay, thank you. Another question. In the last 6 months, my EGFR has dropped from 62 to 57. The lab tests were done based on, in quotes, the standard range, being greater than or equal to 60. Is this the range that all labs use?
Yes, so greater than 60, I didn't go into the stages of chronic kidney disease and stuff, but greater than 60 is kind of the cutoff. After that, a lot of labs won't even bother calculating because if you're above 60, usually there's not a worry, okay? So, if you're 75, that means your GFR is 75. That means your kidneys are functioning quite well, okay? Particularly in patients who are above 60 years old. So there's a lot of 60s in medicine. So 60 is the cutoff, yet I wouldn't get overly concerned if your GFR drops below 60 for one measure. What I do is I look at the trend, okay? Like if your GFR is like 58, and then the next 6 months it's 56, next month it's 57, that's pretty stable. It's below 60, but it's not changed. Do you have protein in your urine? Is your blood pressure under control? Are you on medications can affect that? So it's important not to look at one value, and it's very important not to always look at these ranges because the ranges are there for doctors to interpret. And I know now that patients get their labs online, but they want to, oftentimes they'll go, there's a red arrow there. Oh my gosh, what does that mean? What does that mean? I go, oh, it's slightly out of range, and that's not even an important lab. So be cautious in trying to interpret these values, but 60 is the general cutoff for all labs. And the creatinine is used to calculate your GFR, and it's a universal equation. But don't get too caught up in that in an absolute number.
Okay, thank you. Another question. A lot of CKD patients have issues with chronic pain. What can they take to control pain other than NSAIDs or opioids, neither of which seem like good options?
Exactly. No, that's a really tough one. I'm not a pain specialist, but I get this question all the time because I said, "Oh yeah, you can't take ibuprofen." It's like, okay, so what am I going to take, doc? Am I supposed to suffer? And I say, well, no, I know there are. You got to have something. So Tylenol's fine in doses, but oftentimes it doesn't cut it, and I understand that. If you have osteoarthritis and you have, the degenerative disease where your cartilage is just, burned out, Tylenol often helps. But if there are inflammatory conditions where there's a lot of inflammation, the NSAIDs are particularly good at that. But you can't use these, naproxen, and you can't use like Celebrex either, or Celecoxib, Mobic. Any of these prescribed ones too are not. They're the same thing. They can cause problems. So I think local therapies can be quite effective. Okay, so using, there are NSAIDs that you can rub on called like diclofenac gel or Voltaren gel. That's the only gel I know. It's an NSAID, but you can rub it right on directly on the place that hurts, and it gets absorbed locally and can help relieve like an acute pain. There you can get injections if you have like a really, really bad one joint that it hurts, and you can get cortisone injections, things like that. So the local therapy, and also lidocaine. Lidoderm patches are becoming available over the counter. Lidocaine for lower back pain. Sometimes these are quite effective, yet they're not going to cause you problems because you're delivering them locally, and it goes right in the tissue and it gets used, and it doesn't go into your bloodstream as much. Okay, opioids, unfortunately, it's an epidemic, and I don't personally just prescribe any opioids. I don't even, if someone asks me for one, I don't even have the ability to do that. So, but I'll refer them to a primary or a pain specialist. There are some opioids that do not have the addictive properties, such as tramadol, that can often be used in the first place. For acute pain, sometimes opioids are very effective, but I advise really, really strong caution in using opioids for chronic pain because of the addictive potential. And I often say you need to see a pain specialist really if it's really that bad and making you unable to function. But as I said, local therapy, injections, and acetaminophen or Tylenol can be effective in some cases.
Okay, so Dr. Chen, we have a lot of really interesting questions, but not a lot of time. So maybe I'll ask a couple of more questions, but if we could have you answer some of these questions and then post your answers online, would that work for you?
Sure, of course.
Okay, great. So let me ask a couple more questions in the time that we have. So, do kidney stones damage the kidneys?
Kidney stones don't often cause permanent damage, but if you have a blockage because of a kidney stone, you can uh, cause injury from what we call obstruction. So oftentimes um, that you'll have symptoms of a kidney stone and you'll get worked up and they'll figure it out. But if you have prolonged blockage because the kidney stone won't move, that can cause kidney injury. But kidney stones in themselves don't usually cause permanent injury. Yet there are conditions in which, calcium deposition and stuff like that outside of your usual kidney stone production can cause injury. It just so happens that nephrologists are also experts in kidney stones and their formation. We're not the surgeons, we don't take them out, but we know what causes them. And if you have recurrent kidney stones, often a nephrologist can be useful in terms of figuring out what is causing your kidney stones and how we can prevent them, because we know how painful they can be. And also, there are certain conditions in which these chemicals, like uric acid and calcium, phosphate, things like that can accumulate and actually can cause a little bit of kidney injury. But in general, I would say the answer to that is no, not really.
Okay.
Okay.
And I'll kind of combine a couple. I have time for this one and maybe one more. So one question, can you increase your EGFR, and why does EGFR fluctuate?
Good question. Your EGFR, that's why I say that we look at the trend. The EGFR can fluctuate quite a bit. I mean, it can fluctuate even from 1 hour to like I've seen lab tests done on the same day by accident, or the guy goes in and he gets his blood drawn for one doctor and then the other doctor needs one and he forgot to get it, and so they'll check it on the same day and it can actually be different. Now the EGFR is calculated level based on the creatinine, and the creatinine can vary based on many different things. It can vary it's basically creatinine is produced by muscle and everyone produces it, but men make more than women. And that's why the calculation also figures in men and versus women, because men have generally more muscle mass than women. And also that level can fluctuate. And oftentimes it can be due to medication effects and also how hydrated you are. Sometimes when I see there's a big drop in the EGFR, I'll say, you know what, I think it's because you're on this Lasix and you particularly are a little more dehydrated. You're down 2 pounds. You have no, usually have, a little bit of swelling in your ankles, but you have none now, and your blood pressure is kind of low. You're probably dehydrated, and that's why your EGFR is low. Let's repeat this after you, drink a little bit more water, or maybe we'll hold the water diuretic. And so that's why there's sometimes fluctuations, okay? And so most of the time it's what we call hemodynamic. Sometimes it can be medications, but remember this, we look at the trend. We look at the graph. One point in time is not a really good way to follow this, but in general, the EGFR, if it's at a stable level or it's a depressed level, it generally does not permanently increase.
Okay, well, Dr. Chen, here's one final question that we have in the next couple minutes. Is CKD medical nutrition therapy covered by Medicare, and do you refer your patients out to a dietitian?
Oh, yeah, that's a good question. It's our resources in terms of renal dietitians very limited. I mean, in fact, in my community, there's not a single renal dietitian. Okay, dietary referrals are covered. Oftentimes, though, as I went over, a lot of the dietary things are general dietary recommendations based on if you have diabetes or hypertension or high blood pressure. So there are community dietitians that I refer to, and oftentimes they are covered by Medicare. You may have a share of cost, depends on, if you have a secondary and whatnot. Medicare often covers 80% of your visit, but a dietary, visit isn't often very expensive at all. It may be out of pocket costs, very, very little. So, but sometimes you want to go back and things like that. If I have patients who are at late stage chronic kidney disease and have to be on phosphorus, potassium, and other restrictions, I refer them to our dialysis unit dietitian, and it's actually done, there's no charge, but if I'm worried and they're not getting the education I can give them, I'll refer them and they'll see them free of charge. Well, that's my practice, because I don't have the time or the resources to go through all the dietary restrictions during our visit. But that's in rare cases. So the answer to your question, the resources out there in the community are quite limited. But if you're referred to a diabetes dietitian or a dietitian for lowering sodium and high blood pressure, generally those recommendations are applicable to anyone with chronic kidney disease as well.
Well, thank you, Dr. Chen. Unfortunately, we are out of time, but as a reminder, we will have this posted on our website, the slides, and we'll get to all these other great questions that we had that we didn't have time right now to answer. So thank you again, Dr. Chen, for leading us in such an excellent webinar. Next week, we'll have another one. Just as a reminder, tips for talking with your doctor will be held on Tuesday, September 25th. Hosted by Dr. Sagar Nigwekar, and next month, October 16th, we will bring you Why I Dialyze at Home. So registration is open for tips for talking with your doctor. So when this webinar closes, do not close your browser window. Please close the pop-up that you see and proceed to the webinar evaluation survey. Your honest feedback will help us make our webinar program the best it can be. Thank you for joining us, and we hope to see you again next month.